Thank you for the organizer for inviting me to present our work in this important meeting. My name is Tesfaye Mersha at Cincinnati Children's. My talk today will be racial disparities, air pollution, and COVID-19 outcomes. So my talk, I'll be discussing with you along the following outline. I'll give you some introductory remarks about COVID. And as you know, there's a variation at local and global level. I'll talk about some of the plausible potential reasons for variation in terms of climate, air pollution, and immunities and other factors. I go through that. And most importantly, I think this time gives us an opportunity to look back, not just COVID, for other infectious and infectious diseases in terms of improving racial gap in various ways. So I will give you some conclusion remark towards the end. So to start with as an introduction, I think COVID-19 probably doesn't require introduction. Just to start the discussion, I would say COVID-19 is one of the coronavirus in a big, large family of coronavirus. As some of you may remember, MERS-CoV and SARS-CoV is also part of within this family of coronavirus. The outbreak in 2003. And 2015, and now we have coronavirus or SARS-CoV-2, which is happened in late 2019 in Wuhan, China, and this is another infectious disease. And according to the information we have, it's transmitted from between human and people. So when you talk infectious disease, actually COVID-19 is not the first one, and in our history, in human history, as you can see in this table, even in 430 BC, there's outbreaks, and the days rate varies on those timeline outbreaks. And most importantly, most of us in the literature know that in 1918, the Spanish flu, influenza, that killed over 50 million people. And this, as you can see here, Zika and others has been causing a lot of deaths in the different parts of the world. And of course, COVID-19 is where we are now. So far, about 5 million deaths has been recorded about this disease. So I think I would like also stress at this point that the cost of net preparing for epidemics and the pandemic is really huge. This is the list of some of the most important infectious diseases that happened very recently, I would say. In SARS-CoV, in SARS, over 50 billion, mostly, Southeast Asian, Canadian countries along those lines. And H1N1, over 5 billion. And, Ebola, mostly in African country, over 2.2 billion. And, you can see here the COVID-19. So far in 2000 until 2020, over 12 trillion. You can imagine this trillion spent for COVID-19. And the US budget per year is about actually 5 to 6 trillion. So you can imagine how the world is losing this amount because of not preparing. So the infectious disease have a high price tag. In terms of COVID, actually, we put some articles at the beginning, starting the beginning of this pandemic, and we published in JACI, and other articles that we put out, in terms of looking at the African continent. We put all the available information, and we also put some environmental determinants of COVID-19. So if anyone interested, I'll be happy to share, or you can go Google and find out those articles. So COVID-19 in the US, in terms of cases and deaths, according to my recent search, over 46 million cases recorded, and over 500,000 deaths so far recorded due to COVID. And this has been, as a result of several comorbidities, hypertension, in some ways, asthma, asthmatic disease, and type 2 diabetes has been a most important cause of comorbidities. So, so far in 2020, COVID is becoming one of the #1 cause of death in the US. Worldwide, over 242 million cases, about 5 million deaths recorded for COVID. However, I would say that, the figure, the number I showed you, 242 million cases, is not distributed equally around the world. If you look at the number of cases here, African continent, over 1.3 billion people, you see a tiny contribution of this pie, this figure, compared to Asia or European population. So this pandemic is not distributed equally across the globe. I will come up with some of the plausible hypotheses, as I mentioned before. And the death rate is also similarly not equally distributed. As you can see, even African American, the cases are more than actually the number of cases in this case. So there's this variation, and we try to postulate what are those plausible hypotheses. These are actually the plausible hypotheses that I want to talk to you. I will start with the climate hypothesis, which is seasonality or tropical, whether you live in tropics or temperate zone, could probably matters for the risk of COVID. And this has been also shown that, if you live in the tropical environment, probably you have, you spend more time outside, and then you may have less exposure to COVID instead of if you live in temperate regions. Like, this is basically mirroring the current pandemic, the prevalence rate of the COVID-19 pandemic. So climate could be contributing on one of those lines. And this is basically looking at the cases in terms of the temperate tropical and African area and tropical African regions. As you can see, most importantly, African continents, countries in African countries, the lower part of this figure. And you can see there, the cases are not that big, they're increasing at the slowing rate than those in the United States, where you have increasing at increasing rate. So, if you look back where COVID started in March or even early February 2020, the prediction models all showed that in Africa, over 70 million infections will be observed, and over 3 million deaths were forecasted using various prediction models. So of course, this is for population 1.3 billion population. However, in reality, the deaths actually 250,000, and the cases were not close to 70 million, instead about 8 million. So the mortality rate in Africa is about 2.5 compared to about 8 to 10 in the Western country. Of course, there are various cases. I will come back. The African population, it's a yours is about 70, over 70% is about below 35 years old, probably age factors, which was one of the plausible hypotheses why that could happen. I will discuss on that later. The next hypothesis I have is the air pollution, or the neighborhood or air pollution hypothesis, where we live, including, as an example here, is PM 2.5. So this is an example. We took data early on in the state of Illinois. This is a Chicago suburb area. So we just get the data, COVID records, the cases, and look at the distribution of the map here. And if you look at this map, we use clustering, and we found two major clusters. Without, just you have the cases, we didn't take anything, but it clustered into two groups. When we look into details of clusters, cluster one is actually, we found more confirmed cases on cluster one, and higher population, higher Black population, and higher food stamp, whereas cluster two showed the reverse, more white, less food stamp. So, this is just based on zip codes. So what we say here is, actually zip code classify racial groups much better than county. If county-wise, this falls in the same county, but the zip code, you will see different clusters, which is much at a high resolution than at the bigger resolution, which is more county level. So I think we need to look more closer. Even this is a solid. We need to more to address level actually, because that gives us a more high resolution relationship. And because of that, I think some years ago, you say today outlined in the front page that whether your zip code is more important than your genetic code, which I believe this is very good, powerful saying, because we need to look where we live instead of just one way of looking genetic code. So we need to target high risk neighborhoods instead of just high risk individuals, because outdoor air pollution are not under control within the control of individual. So we need to target the neighborhood, so that if you change the neighborhood, definitely the individual will benefit for those conditions. As I mentioned, air pollution is another important factor in these neighborhood factors, which usually called silent killer. And there are many deaths because of air pollution, but we might not see it in direct way. But it affects a number of systems: stroke, heart attack, and heart disease, and cancers, all are affected by air pollution. On the right side of the figure, this is an interesting figure. This is November 3rd before COVID 2019. This is Delhi, India. You see the air pollution, even you cannot see even next to a person next to you. Whereas during lockdown in March 30th, 2020, you can see how very clean this environment and will have an effect on health. So I think we need to look at how this air pollution contributes to our health, and this can be actually explained this way as well. In PM 2.5 here, if you look, the x-axis is three population. We have Black, Hispanic, and white, and it's a busy slide. But if you look this part, the white population, they are less exposed than they cause PM 2.5 to the environment. Basically, they contribute more exposure, and they have more, they contribute more PM 2.5 to the environment, whereas they expose less to the PM than they contribute. Whereas the Hispanic, they expose more than they contribute. That means they live in a neighborhood that's polluted, but basically they are not the one contribute that pollution. The same thing for Blacks. They are exposed to more PM 2.5 than they themselves contribute to the environment. So this is more of the environmental injustice, where you live, but you are not really the sole contributor of the environment. So you can see Blacks exposed 56% more than they contribute, Hispanic over 63% than they contribute, whereas white exposed less than 70% than they contribute. So if you look at this scenario into the US map, you can see the first top left panel is African American, and the right Latino. You can see the population distribution is northwest eastern part of the country. Most Blacks are concentrated in this area, whereas Latino in southwestern part of the United States. And this is reflected in PM 2.5 and COVID. You can see the COVID map is probably, it's a mirror reflection of these two populations. So there is a big, overlap where people live and their risk factor in terms of air pollution and COVID-19 in this case. So how the air pollution affects a human being? I think this is thanks to Debbie. This is a slide from Debbie. I found it's very, very relevant to show this. You have a normal cell. Basically, the air pollution, oxidative stress, create a free radical and attack all the cells, and the cells become dead. So the cell with oxidative stress would damage our inflammatory system. Cellular damage occur. This increased susceptibility to infection, including COVID-19. So this is, a silent killer, which is an indirect effect than, you see in another case. The other factor is comorbidity hypothesis. think there are multiple comorbidities. I don't want to go to the details of each. If one interested, there's a paper here cited. So basically, there are more comorbidities that probably, have a big effect on somebody's COVID status. Being diabetic, obese, and racial ethnicity, all these factors actually contribute to the high rate of COVID in certain ethnic groups or racial groups. Well, if you look, most minorities known to have a high comorbidity of this outcomes, and that's why there is, if you look on this figure, you see, high COVID-19 in African American than the population. So they have actually they are more exposed than their proportion of sample size, their population. African American here we have about 12%, but they are exposed pretty much over 25% to the COVID-19. And the same is true for Latino and Asia, something similar proportion. But you see in white population, they are the population, they are exposed, less exposed to the percent population of the white population. So this is related to the comorbidities and other factors as I mentioned. Well, as I already mentioned that this difference in the health risk is not a new thing because of COVID. It has been there for years. You can see all these named diseases. There is much high rate in blacks and the Hispanics than in other populations. So COVID is just another layer of disparities on our list. Well, it's also known that there's with the relationship with the COVID and asthma. In some cases, some articles there's high relationship, direct correlation. In some cases, there is no relationship. So it has to do with the type of asthma, whether type 2 or type 1 type of asthma. So for those with type 2 allergic status, the COVID is there's lower SARS-CoV infection of COVID risk, whereas if you are non-type 2 types, you have a high risk of COVID. So there's a paper in JACI, anyone interested to look at it. But all asthma are not the same. Asthma is an umbrella term that is associated with different endotypes. The other factor I want to mention is the genetic factor, racial difference. Basically, in most cases, the SE2 gene is known to be, a gene that's, an entry point or receptor for SARS-CoV-2. So whether the gene frequency on the allele frequency in this gene contributes for racial differences. So early on, there was a JUA study in a New England Journal of Medicine. And this study actually, although the sample size is not that big, they didn't find that gene, which everybody was puzzled because everyone was thought that was a contributing receptor. But it wasn't a big or it wasn't found in this JUA study either. So another study looked at it. Again, it's not that gene. Another study found out that some SNPs in the genome was actually inherited from Neanderthal. So these are the haplotype from Neanderthal. So there's also some studies that anyone interested can look at this nature study. So the other hypothesis is evolution. If there is an evolutionary difference between humans along the way, because the Th2, Th1 cytokine was due to infection. This figure shows out of Africa hypothesis, people move to, once they are out Africa, they move northeast and all part of the globe. So in Africa, in the tropics, they have high pathogen abundance. That means, we are always fighting with those pathogens, virus, bacteria, all those things, and they have pretty much upregulated immunity and compared to, temperate or other regions. So as a result, being in the temperate, you have low exposure to pathogens and worms, whereas in tropical African country, you have high exposure to worms and pathogens. And when there is something like COVID, you have you have a high reaction because you have you haven't exposed to that kind of situation, and which we call it the creation of cytokine storm. So that upregulation of the immune system creates a cascade of activity. Whereas in Africa, it's because of exposure going on for many years, for generations, is immoderate immune reaction. So this could contribute to that variation, which is due to the pre-existing immunity in Africa compared to tropical or temperate regions like North America. The other factor is when the trained immunity, whether the BCC, the vaccination you take for malaria, whether that prior immunity or vaccination protect us from getting or severity of the COVID is reduced on that. So this is a vaccination map around the world. You can see high vaccination regions, but it is somehow parallel to the low incidence of or low prevalence of COVID in some cases compared to high less vaccinated area. So this is something we can look visually, but it requires more detailed study whether that's actually the case. So finally, the age hypothesis. I think we already know that children are less affected by COVID, and that is related to the deterioration of immunity in our immune system as we age. As you can see, the higher effect of COVID in this map, as in this figure, over 75% has a skyrocketed death rate than the young children. So this is another age is an important factor, and this is from recent data from American Pediatric Academy of America Pediatric Academy. You can see the adults versus the children. There's some high peak in children here, but this could be due to school opening and a lot of exposure going on. But as yesterday, Wednesday, I heard now CDC is approving for children 5 to 11 years old. So this may go down somehow as you move on. So the other factor is, the difference between male and female, and male sex is a risk factor. As you can see in this publication, more effects on male than female across years in various countries, almost universally. So this is another factor. Sex is different is one of the important things to consider in all studies. So finally, I think I will close to, what do you need to close this racial gap or geographic variation? We need to look at from multi-level perspective. The first thing is, there are social and economic health inequality going on, and we need to look individual level, neighborhood level, and national level. As I mentioned, something we cannot control should be controlled at the national level. So there is, race segregation, exposure, and safety and violence. All these factors actually contribute to somehow to stress our behavior, and which eventually contribute to our health, which COVID is one. Well, what are other factors? How do you determine this? I think all the bad things I mentioned on the left side, the socioeconomic access to care, all this discrimination, unemployment, these are big risk factors. How do you reverse this case? Of course, the solution is expanding housing and all this provide food and service, have support education system, and parenting, community service, and safe environment. All these factors could alleviate the racial gap that we see in our society. So in my view, health disparity, what we see right now with the COVID or others, are preventable or at least modifiable. So, so how do you, what are the opportunities to improve racial gap in post-COVID era? I think, as I mentioned, COVID gave us an opportunity to look back our health system. So there are 3 pieces I mentioned. We need to prioritize health system for everyone, foster community resilience, and promote equity. So I call them the 3 P that we need to address or to achieve this is a goal of increasing health equity in our community. So in terms of COVID, I think the progress made, there are really great success of scientific discoveries. We can see COVID is just in a year, we have vaccination. So, imagine how many days we could have now that if no COVID vaccine within a short time, compared to how long it takes malaria and over years from, for COVID. So this is a success story that scientific discoveries really make big leap in our community. But I think there's a vaccine, but also there is global disparities in vaccine distribution. For example, less than 2% of all COVID vaccine have been administered in Africa, and most Africans actually will not receive COVID until 2023. So you can see most African is a desert, vaccine desert, I would say, than other countries. So I think in some cases we need to think of how we reach out others. And most importantly, I saw that the European travel and tourism sector plan to adopt a COVID-19 passport. So you can imagine those countries, those regions without passport, how they can, have free access to other countries if you implement this passport, COVID-19 passport systems. So finally, I would like to conclude my talk with, COVID-19 racial gap reinforce known health disparities. It's not the first thing and it not be the last, but it's reinforced actually. It will give us an opportunity. There is high COVID-19 risk within minorities because of where they live and where they work and everything, and the income, housing, and access to health care. And of course, all this compromise our respiratory system and others, which is directly translated to some of the risks that we see in COVID. And in my view, this is a multi-level, we need a multi-level intervention because the problem is multifaceted. So again, I want to stress that we need to, how disparities are at least modifiable, we need to act in a very coordinated way. Finally, I would thank my group here in Cincinnati Children, postdoc Yadu and Sudhir and others, and collaborators and Nero Hershey, our division director, Jonathan and Mark Rothenberg and others. And there's fundings, Cincinnati Children, Center of Environmental Genetics, NIH, NHGRI, NHLBI, and Center of Pediatric Genomics here at Cincinnati Children for some of the financial support. Thank you very much. If any question, please.